Good afternoon. It's my pleasure to welcome you all to the afternoon session. And this session was organized by EUFAS, by the European Federation of Addiction Societies. I'm Marcin Wojnar, psychiatrist from the Medical University of Warsaw in Poland. And I have a pleasure to co-chair this session with Professor Colin DRUMMOND, addiction psychiatrist from King's College in London. First, we would like to introduce EUFAS, the European Federation of Addiction Societies, and I would like to ask Benjamin Rolland, professor of addictology from the University of Lyon in France, to tell us exactly what is EUFAS. Benjamin, please.
Hello, everyone. Thank you very much, Marcin. I'm going to talk in French, because I've supposed that the audience would be French in majority. But of course, we can exchange in English after that. So, donc, je vais parler français pour présenter l'EUFAS.
I'm going to be speaking in French for the French public. EUFAS is a European Federation of Addiction Societies. It brings together medical societies. In France, these are mostly addictologists or doctors, but in other countries, they are psychologists. So they are national societies of psychologic addictology. It sounds funny in French, but it's the case in other European countries. So you see on the map, it's not up to date. It's not up to date on our website. We're going to update it shortly. You see that many countries have associations, addictology, medicine, or psychology that are members of EUFAS. Two joined us this morning, Slovakia and Turkey. So this is a wide vision of Europe. It's not the European Union. It's Europe as a continent, which brings together all these societies which belong or will belong to EUFAS. The countries are represented within the executive committee. And this morning we had our General Assembly to review several points which I will talk about now. The main missions of EUFAS, first of all, is to discuss, to exchange. Maybe our colleagues will have a different point of view, but EUFAS is a think tank, a place where you try to identify how the addictology issues are in Europe, the heterogeneity of care, training, research, and to try to see why there are this difference, what are the issues, and how can we correct these issues. EUFAS, as for main mission, is to improve the care of addicted patients in all European countries, to improve prevention, to try to better structure and federate the research and training initiatives at the European level. And Jürgen BRAMNESS will tell us about some research they did on graduation, on diplomas and training in addictology in Europe. EUFAS has links, as relationships with the main European associations, the main one being the European Psychiatric Association, EPA, and one of the former presidents of EUFAS is now the president of the EPA, Professor Dom, who is not with us today. And even if it's part of the missions, it's part of the future missions, is to lobby the European powers to better federate the addictive issues with the European institutions and national institutions. We have several partners. The two main ones with EPA, the European Psychiatric Association, and the MCDDA, the equivalent of the OFDT, or OFDT is a French branch of EMCDDA. At each convention of the EUFAS is present and organizes joint sessions with these organizations. We have other partnerships with ESBRA, the European Society for Biomedical Research on Alcoholism, for mostly fundamental research, but some of us are also members of ESBRA, and ISAM, the International Society of Addiction Medicine. There are other partnerships that are being set up with the World Health Organization and other specialized companies such as the Pain Society. The connection with addictology is obvious. EUFAS has publications. It publishes data and papers, European surveys on several subjects. There was a research on addiction research in Europe. Mr. BRAMNESS will talk about training and diplomas of addictology in Europe. Regularly, these questions are being reviewed, and in the future projects, there are the substitution treatments, since they are heterogeneous practices and access to the substitution treatment, and we will compare France and the States. Other subjects such as access to the young public. This is a future European survey. We are present at the conventions of our partners. Today, this is an example, and we thank ATHS for welcoming us and for this EUFAS session, but we are present in European conventions, Lisbon Addictions, the annual congresses of EPA, etc., and more national congress. EUFAS also, together with the journal European Addiction Research, we have a prize of the European scientist. It was annual prize to recognize a career on past work. You see all the prize winners since 2016. It will be probably now we will probably give that prize every 2 years. You see well-known names in the addictology sector. That's in partnership with the European Addiction Research to give an award to a European researcher for what he did scientifically, politically throughout his or her work. EUFAS is also involved in European projects supported by the European Union. The last one was PHOENIX. It's a consortium project around risk reduction in Europe. PHOENIX was supported by associations and university involved in risk reduction, and the purpose is to try to identify the main initiatives, innovative initiatives for risk reduction, to describe them, to reward them, to promote them at the European level. So the European Union can identify the most original projects in the last few years in terms of risk reduction. And EUFAS was a natural partner with other European partners. The final report was just delivered to Europe. There will be a scientific publication. We have a website. We also have a Twitter account or X account where you can subscribe. That gives regular news on the life of EUFAS and the different societies that are members. And as I said, we have this partnership, the European Addiction Research Journal. And if you are a reader of that journal, as of next month, there will be a page in each journal dedicated to the life of EUFAS, and the first page of EUFAS will be dedicated with what we did today at ATHS. We will talk about the symposium that welcomed us, and we will talk about what we heard and what we said at our general meeting this morning. This was the old, the former executive committee. It's changed now, and people with role. Our president remains the president, Professor Drummond, Jürgen BRAMNESS, myself as general secretary, and the bureau. We have Cristina Ribeiro, who's now the vice president from Portugal, and I would like to thank Karen Herschel, who is a chief editor of European Addiction Research, and she's very involved in EUFAS. Thank you very much.
Thank you very much, Benjamin. We'll keep the time for questions at the end of the session.
Merci, Benjamin. Nous aurons les questions à la fin de la session. Maintenant, j'ai le plaisir d'inviter Jürgen BRAMNESS, qui est un psychiatre addictologue, professeur de médecine des addictions.
Anglais. Tu parles en français, en anglais. Change le...
Addiction training across Europe.
Thank you, Marcin, so much. I'm going to speak in English, but I have had help from my good friend Benjamin Rollin to translate the slides into French. Now I have corrected some of my own statements after they were translated, so those of you who know both languages may react to some things, but I think that's okay. I'm going to present the results from a survey we did amongst all our colleagues in or our member societies in the EUFAS on addiction training in medicine and psychology across Europe. And this was done by a lot of collaborators. You see them listed all here, many from most of people then tightly involved in the EUFAS organization. And this is a publication that is online now, but will be printed in a very shortly upcoming issue of European Addiction Research. So it's available now online for those and free of charge, full text for everybody. Benjamin has already taken you through all this previously in his good lecture, but I want to emphasize some of the missions for the EUFAS as a society or as an organization, because they are core to why we wanted to do such a survey and look into what is the situation for training amongst the addiction psychologists and addiction medical doctors in Europe. It has to do with the core missions and aims of EUFAS, that we should improve the care for these patients, we should improve prevention, we should look into treatment systems, we should address the different financial resources allocated to the field. We want to do something on reinforcing addiction research. We want to improve and harmonize prevention and treatment. And one core thing in such a task or mission would be to look into what are people taught in their training to become addiction psychologists and addiction doctors. And also maybe this will come out of this paper when it's published, is that we may suggest policies in the educational area to improve the harmonization of education across Europe. This is also important because there is a lot of traveling now between different European countries within the Union, and also for Norway, who is still outside the Union. But we have collaborations across the countries, and harmonizing our ways of addressing this field would be of importance. So I've said some of this already, but these are the foundations of why do this survey, because addiction training is needed. They are relatively new fields, addiction psychology and addiction medicine, in the field of clinical practice, at least in some countries. Other countries have a longer tradition, but it's a fairly new medical and psychological specialty. And there is a great, and we know this from talking to colleagues across Europe, a great variety in the background and training of the different specialists in addiction medicine and addiction psychology. So this is maybe a problem, and we wanted to look into that. And maybe is there a basis for unified sort of European education within these fields? And maybe such a survey could give at least some basis for answering these questions. Also, looking outside the education, looking into the sort of reality this education plays out in, it is important to say that a lot of the treatment are given by non-governmental organizations, be it idealistic private or even commercial private deliverers. And this may also be a challenge when coming to standardizing what is given as treatment for patients. And we must admit that in the past, at least, and unfortunately still in some places, ideology, morality, and religion still are very present rather than evidence-based treatment. So a good educational background is, I think, a basis for changing this that in some cases is not optimal. And it is true, and still is true in most countries, and still I think that other professions than psychologists and medical doctors have dominated the field, but there is an increasing use of our professions also within this field, and I think we need to be sure of some of the educational basis for these specialists amongst us. Now, how did we do this? We wanted to do a survey looking at all aspects, or as many aspects as possible across Europe, and obviously it's a difficult task. We sent out questionnaires we had 34 member societies within the EUFAS, and they were sent out. They're in 24 different countries, and we asked if they could forward these things, because not everybody was in the position that they could answer these questions, even though not very complex. There was one arm for the psychology and one arm for the medical part of the survey. And what we did when we got responses from the different countries and member organizations, we fed it back. We organized the data they had given us and fed it back to the organization so that they could give us feedback. Before designing the survey, we had a so-called Delphi process. That's a process where we are putting up suggestions and putting it into a feedback loop. And the experts that are amongst the co-authors of this paper were asked, is this a good way to ask? Should we ask it differently? And there's a whole process that is quite formalized that was on the basis for how developing this survey. And this is generally how we do surveys when we have a process of doing surveys within the EUFAS. The expert group consisted of 14 addiction clinicians and researchers from 10 European countries, and the countries are named here. And the process went, the survey was out there from April to August 2021, so already it's gone 2 years. Tells you a bit about the process of producing such a survey and managing the results. And as I said, the replies and our interpretation of these replies were fed back and revised by each of the responders. So in order to try at least to qualitatively or qualify the data given in our interpretation of them. Now I'm going to give you a lot of graphs and a lot of figures here, but hopefully it will illustrate some of the things that we covered in the survey. Now this is a graph showing the length of the training in addiction medicine across Europe. In the blue columns are in some countries, it varied between a minimal amount of time needed to be considered an addiction doctor, and they had a maximum time. So, for example, in the first country, Austria, you could make do with 6 months, but the maximum training was 48 months. And It went from countries having very few weeks, like you see Germany here has 2-week course in addiction medicine that qualifies people to become addiction specialists. That's the formal training. While the formal training in the country that had the most was Norway, where we have 5 years of addiction medicine training to become a specialist. So it varies quite a lot across different countries. And as you see, some countries do not have formal addiction training, medicine training. That's countries like Italy, Lithuania, Luxembourg, and Poland. Then there is a variation in who approves different specialists, and this has maybe a lot to do with how healthcare system is organized in different countries. And you see that in 6 countries, the government approved the specialists. In 6 countries, professional societies approved the specialists. In 4 countries, universities approved the specialists, and in 8 countries, and there were no specialties approvals, specialist approvals. Now, you could look at the number of addiction specialists in real-time figures. You see the graph on the left here, where you see that Germany has really the highest number of addiction specialists. You might relate that to the short courses that are given to become an addiction specialist. But maybe more interesting, on the map there, you will see the number of addiction specialists, the relative numbers, that's per inhabitant in the countries, where you see still Germany is very high, but Finland, Norway, France, and Austria, come up quite high as well. Sorry for the geography there. Now, what did it contain? We ask people what are they involved in when they do this training. Is it theoretical learning? Is it clinical supervision? Do they do tutorials, practical courses? Are they educated in non-pharmacological interventions, in pharmacotherapy, different procedures, medical emergencies, complications, and dual diagnosis? And as you see here, most countries that had a specialty trained the doctors in all of these fields, with some differences, and these are marked in the lower here. You can read. It's probably not easy to see, but the 2 yellow ones in the middle there are in fact courses that are given to doctors not putting out a specialty even. So some countries will have training even if they don't have an official specialty. One other way to approach this is to look what is the academic staff that provides this training, and what is the position of addiction medicine in academia, and are there professorships? And here I've divided into part-time and full-time professorships, the part-time ones being the orange columns. And you see there is a great variety, with France absolutely leading the course with, I think at that time it was 23 full-time professorships in addiction medicine, which is beyond doubt the most in Europe. While you see a country like Croatia has quite a few part-time professorships, and then United Kingdom in 3rd place. And then we move to training in addiction psychology. Here we got much less answers. This may be a fault of ours, but I think also to some extent it reflects that addiction psychology is not that well distributed across Europe. So here we only got a response from a smaller number of countries. And the 2 countries that had the longest education for addiction psychology were Sweden and Croatia, with a full 5 years educational run. And then you see that other countries follow either by having some can have a longer education, but the required education is lower, ranging from 6 months, half a year, to up to 2 years for the lower ones, and quite a few countries not having specialty in addiction psychology. Also here, government, professional societies, universities will approve the psychologists, differentiating more or less along the same lines as you would see for the addiction medical or addiction doctors. Now, the number of addiction psychology specialists in different countries where we got response, and I know these responses are not complete because I know there are countries that didn't respond to this, but after having sent numerous emails, we gave up, and are the numbers we see on addiction specialists in psychology field from some of the countries we got responses from. Likewise, as I presented for the medical profession, also in psychology, there are professorships when we look into the academic side. And here, Croatia, who had many addiction psychologists, also have many addiction psychology professorships. And also Germany, quite a few, at least part-time, and Austria, quite a few also part-time. These are probably people who either hold a clinical position or divide their work between addiction psychology and other parts of academic psychology. Now, a summary of all this, and here you see the paper as it will look. This is my copy. It's as a free author copy, so I'm not sure if I'm allowed to show it, so you can blink. But 16 of 24 countries had some sort of addiction medical training, with a median 24 months as their training period, but a wide range, as you saw. 7 of the 16 countries where we got some feedback from had addiction psychology training, and it also here had a wide range ranging from 2 to 5 years of training. Now, the content of the education varied, but most countries covered all the fields that we asked for, and tutorials and interactive learning and medical emergencies were the fields that were mostly lacking and that where there is room for improvement. Now, the number of addiction specialists varied greatly across different European countries, and this has obviously something to do with what is the definition of an addiction specialist in the different countries. And here we have a long way to go to harmonize any inter-European collaboration, because an addiction specialist will mean one thing in one country and another thing in another country. And hopefully we can start there and have some work done on harmonizing rules across Europe. And certifications were given from different kinds of institutions. And this may also be some of the problem that we need to address if we want to go further and try to do something in the way of harmonization of education within addiction psychology or addiction medicine in Europe. So with that, thank you.
Thank you, Jürgen. And now I would like to invite to the stage Professor of Medicine, Internal Medicine and Addiction Medicine, who came to us from United States, Honora ENGLANDER. Honora is professor at the University of Health and Sciences in Portland, Oregon, but now for years she's visiting as a professional visit at the University of Lyon. So she's partly from France at the moment. And Honora will share with us her study on comparing systems of access to opioid substitution treatment between France and United States.
Bonjour à tous et à toutes, et je vous remercie.
So hello everybody, and thank you very much for giving me the opportunity to address you today.
In English because I'll be more comfortable, but again, thank you so much for the opportunity. Perhaps in a few months I can do this in French. So today I'll be speaking about comparing methadone and buprenorphine care systems between the US and France. And I do want to acknowledge the funding for this work, which comes from the Franco-American Fulbright Commission, Neurodis Foundation, and the Vinatier. So to begin, I'll provide a brief history and context, which really is important to understanding the divergent paths around methadone and buprenorphine between these two countries. So taking a step back around US drug policy, one could start before this, but at a high level in 1914, there was the Harrison Narcotics Tax Act, which regulated opioid and cocaine, and really was deeply rooted in racist propaganda, or supported through racist propaganda in passing this act. And this act later in the courts was interpreted to suggest that physicians, or to create a situation wherein physicians in the United States cannot prescribe opioids for treatment of opioid use disorder. And this has enormous repercussions and persists today. And I'll explain this further, but it's really, this is what has led to the system of opioid treatment programs, or OTPs. I'm going to fast forward now to the 1970s, where President Nixon declared a war on drugs. Again, rooted really in politics and less in drug use. Reagan-era drug laws followed in the 1980s, which created mandatory minimum sentences, increased penalties for drug possession, and increased funding for drug enforcement. And again, these policies, which now are decades old, have really enormous repercussions both on how care systems are designed and also on the experiences of care and the experiences in the United States for people who use drugs. Fast forward again to 2002, where the Data 2000 Act allowed for buprenorphine prescribing for treatment of opioid use disorder outside of opioid treatment programs. So this was a really important change in this time, which expanded buprenorphine to what are sort of known as ex-waivered clinicians who had some brief 8 hours of training in how to prescribe buprenorphine. And this ex-waiver was subsequently or ended by President Biden in 2002. So again, kind of taking a very high level look, drug policy in the United States really is one of crime and punishment, which has led to mass incarceration, punishment for people who use drugs, really disproportionate harms among Black and other people of color, and segregation of methadone from the rest of healthcare. And I'll talk about what this looks like today. But leading to a highly structured, inflexible care, which really places the burden of care the burden of treatment on patients. So there's increasing and pressing need in the era of fentanyl in the United States to expand treatment access. As others have talked about earlier in this session, in this conference, over 100,000 Americans die each year from overdose deaths, and fewer than 15% of Americans with opioid use disorder receive methadone or buprenorphine, which we all know is the most effective treatment for opioid use disorder. There's also a disproportionate treatment gap and worse morbidity and mortality amongst minoritized populations. So now taking a step back and looking at a timeline and history in France, and I want to thank my colleague and friend Anthony Plas for these slides, or for this slide, which I've adapted. But in 1970, drug use was prohibited by law. However, in 1987, there became legal authorization of syringe sales in pharmacies. And in 1995, really pivotal changes in response to the HIV/AIDS crisis in France, where harm reduction policies were enacted. And this included free syringe distribution, efforts to increase methadone and buprenorphine. Again, fast forward to the mid-2000s, where there were formation of CARUD and SAPA. And then in 2016, laws permitted limited trials of drug consumption rooms. And what we can see in France is, again, a timeline that mirrors the adoption and really true integration of harm reduction policies, a public health approach rooted in harm reduction since 1995. And presently in France, over 80% of people with opioid use disorder receive methadone or buprenorphine. And this is a figure of utilization of buprenorphine in blue and methadone in red over time, and data from the OFDT. So as we then think about methadone and buprenorphine care systems, I'm now going to move from the historical context to thinking about access. And I've used a conceptual framework just to organize some of this, thinking about kind of how is the system organized, and how can people then access the system? What are the ways in which the system accommodates patients and their needs, and what are patients' experience in care? Before I jump in, I do want to make the assertion that opioid use disorder care should be minimally disruptive. And this is somewhat of a simple idea that with colleagues, we've sort of expounded upon in this paper. But the figure is more
ligado al
complicated than
consumo de
the
droga
idea.
deben ser
idea-
perturbados como mínimo. Es decir, la
We want
idea
to
es
limit the burden of treatment and limit the burden of
queremos
illness
limitar
and make those
los cuidados
aligned with an
y
individual's
también la carga que
capacity
representa
for
la
work
enfermedad y
and
que
their
todo
life
se pueda
demands.
alinear
And
a la
so,
capacidad del
again,
individuo
just
de
planting this
trabajar y
idea of what is the
satisfacer
work of
sus
treatment
demandas
and what
vitales.
is the burden of
Por lo
illness and
tanto, hay
how
que
do these
pensar
compare in these two different
cuál es el
countries.
tratamiento y cuál es
So to
el peso de
begin,
la enfermedad
thinking about
y
how is care
compararlo.
organized and available, and in what settings is care
Por lo
located,
tanto,
and who
cuando
delivers it.
pensamos en los cuidados
So I
y
also
los
just want to
tipos
make a
de
few definitions.
entorno en
As
el
I
cual
mentioned
se
in
da
the US,
estos
an opioid
cuidados, me
treatment
gustaría
program is the
empezar por
only
dos
setting where
definiciones. En
patients can
Estados
receive
Unidos,
methadone.
OTP es
Also,
el
at opioid
único
treatment programs, patients can receive buprenorphine or naltrexone, the other
ambiente donde se
FDA-approved
puede
medications
recibir
for
un
opioid use
tratamiento,
disorder in the United
programa de
States.
tratamiento
These
de
are federally
opiáceos.
licensed and
Se puede
highly
recibir
regulated
la
treatment settings. They're federally
buprenorfina,
licensed.
la
They're
metadona
regulated
y
at the
estas
local and state level
OTP
often.
son
And their
lugares
services include
legal
medication as
donde
well
los
as
pacientes pueden
counseling,
recibir
groups, urine
metadona.
toxicology, and periodic
En los
assessments.
Estados Unidos también
In France, we have the
ofrecen
SAPA, or Centre de Soins
buprenorfina y
d'Accompagnement et de
naltrexona.
Prévention en
También se hace
Addictologie.
análisis de orina y la
And
evaluación
these are centers
periódica.
that
En
offer
Francia,
free
sin embargo,
longitudinal
tenemos
anonymous
AXAPA, que
care
son
to people
centros
with
de ayuda,
addiction
acompañamiento
and
y
also
prevención en
deal with
adicciones
risky or
que
harmful
ofrecen
substances
atención
and those
gratuita
around them,
de
including
forma
initiating
anónima
methadone, also
a la
including
persona con
buprenorphine care.
adicciones o consumo de sustancias
SAPAs
de
carry out the
riesgo
mission of
y se
prevention,
incluye
risk
la
reduction,
metadona y
medical,
la
psychological, and
buprenorfina.
social.
Y se
So
lleva
how are the
también
systems organized? And I'm
unos
going to start with
cuidados
methadone.
psicológicos
In
y
terms of
sociales,
initiating
además de
methadone,
atención
which is
médica.
a
Bien,
process that
voy a
can take
empezar
weeks to months.
a
In the
hablar
US,
de la
they've
metadona
said
respecto de esta
methadone is only
organización.
dispensed through
La
OTP.
metadona es un proceso que
Also,
puede
in hospitals,
extenderse
there is
en
an
semanas o
exception wherein
meses. En
hospital
Estados
clinicians
Unidos,
can
solo
start
la
methadone for
OTP
the treatment of
puede
opioid use
dar
disorder, but
metadona.
once the
Los
patient is
hospitales
discharged, they have to
puede ser
receive
una excepción,
methadone from an OTP.
pero una vez que
And
el
hospital
paciente se va del
initiation is
hospital, tiene que
generally
ir
across the
a
United
una
States
OTP en
still
Estados Unidos.
relatively uncommon, though
El
certainly
acceso al hospital en Estados Unidos no es
happens in
muy
certain
habitual de
areas.
todas formas.
Whereas in France, we have the
Pasa
SAPA
únicamente
for
en algunas
initiation
zonas.
and also
Sin
any
embargo,
hospital.
en
However, in
Francia,
France, every hospital has an
para
ELSA, which is the
inicio
equivalent of an
del
addiction
tratamiento de
support
metadona
service.
tenemos la XAPA
For
y
maintenance,
cualquier
methadone
hospital
must be
que tiene
dispensed
servicio
from an opioid
generalizado
treatment
que se llama
program. There are no
ELSA.
prescriptions.
Se
Patients cannot get methadone for
puede
opioid
dar
use
la
disorder
metadona
at pharmacy in the
únicamente a
United
través de
States.
la OTP de
There's no
Estados
primary care,
Unidos,
specialty addiction
decía,
care,
y
or
no se puede
pharmacy-based
conseguir
methadone
metadona en
care.
farmacia. Por ejemplo,
And
no
importantly, methadone is also
hay
not permitted or
ninguna
feasible in many
posibilidad
residential
para
addiction
metadona
settings.
y no se permite tampoco
Whereas in
en
France,
muchos
methadone can be prescribed
establecimientos
by any
de
clinician in
adicciones.
any setting.
Mientras que en
And
Francia
this could be in a
la
SAPA, in a
metadona lo
specialty
puede
addiction
prescribir cualquier
setting, or
médico
really
en
in
cualquier
any other
contexto,
healthcare setting
ya sea XAPAE
for
o en
maintenance.
atención
And
especializada
they can
a las
people can get
adicciones.
medication through any
Y
pharmacy.
cualquier médico de atención primaria
When we think
u
about
otro
buprenorphine,
puede
the differences
prescribirla
are less
y se puede igualmente
remarkable.
dar
In the
en
US, currently,
farmacia.
any clinician can
Respecto a
prescribe
la
buprenorphine and it can be
buprenorfina, las
dispensed from
diferencias
any
son
pharmacy.
menores. En Estados
However,
Unidos,
it was
cualquier
just
médico puede recetar
within the year that this
la
changed. So it was only in
buprenorfina, se
December of
puede
2022.
dispensar en cualquier
And before
farmacia.
that, clinicians needed this special DEAX
Y
waiver.
en realidad,
And
antes de
still
diciembre
in
de
the United
2022, los
States,
médicos
buprenorphine is not
necesitaban
permitted
la
in many residential treatment programs, such that people are
exoneración
forced
para
off
poder
of this medication to be
prescribir
able to
la
access residential
buprenorfina.
care.
Y en muchos
In the US,
programas
in France,
de
buprenorphine is
tratamiento
widespread.
residencial
Any
no estaba
clinician can
permitido.
prescribe, and it
Mientras
can be
que en
dispensed from
Francia
any pharmacy.
la buprenorfina está muy
So this is a map of
extendida
the
y
United
cualquier
States,
médico puede
really
recetar
showing
y se
this
dispensa en
enormous
cualquier
treatment
farmacia. Aquí
deserts
hay
for
un mapa de
methadone,
Estados Unidos que nos muestra
where there are
realmente
areas that are larger than the size of France,
donde
where
el
there simply
tratamiento
is
con
no
metadona
methadone
no
access because
existe.
there's
Fijaros
no
que hay zonas
methadone
más grandes que Francia
within
donde
drug
no hay ningún
distance.
acceso a la metadona.
And when you overlay, this is a map
Y no
that
hay manera
overlays
de obtener
buprenorphine
metadona,
in
por lo
addition to
tanto,
methadone,
a una
and
distancia
shows
razonable.
basically that
Y
a
luego
count
si
of medication for
voy
opioid use
a
disorder
añadir la
types within a 30-minute
buprenorfina a
drive.
este mapa,
So you
se
can see
observa
there remain really vast treatment deserts across broad
a
geographical
menudo
areas where people simply
sigue
cannot access
existiendo esos
buprenorphine.
desiertos,
With COVID,
esas
there's been the
zonas
emergence of
imposibles
telehealth
para
for
conseguir
buprenorphine, which has really been
fina.
access
Veis
and
las
increased
manchas
attention
pues deja de
here,
gotear, que es lo
but
que
treatment gaps
que es lo que
remain.
hace falta.
que con un recuento
Vale.
en un radio de
By
30
comparison,
minutos
in
en coche para
France, this is a
encontrar el
map of the
lugar. Por
SAPA
tanto, hay
across
muchos lugares
France, and you
donde
can
no
see
hay
that there's a
acceso
SAPA
ni a la
within
¿Qué te iba a
metadona
within
ni a
decir?
la
each
Ha venido a casa,
buprenorfina.
ha
each region
reparado
in
Sin embargo,
France.
tenemos aquí la
And this
el
is,
mapa de la
this is
AXAPA,
regulated
Centro
and
de
supported.
Especializados en Adicciones, están en todos los departamentos francés.
And
Todo está
also, there are
reglamentado y
pharmacies
apoyado.
across France, and I want to
Y
thank
también
Mathieu Chapi
hay
for
farmacias por doquier en
helping
Francia
me
y quiero
understand some of
agradecer a
this.
Mathieu Chapi
But again, here's a map
por la
of
ayuda
the
que me ha
density
dado para
of
entender todo esto.
pharmacies in
Una vez
France,
más, un mapa de la densidad de
where
farmacias
within
que
any
hay en
specific
Francia,
population, I believe it's 2,000 people, there are a certain
donde
number of pharmacies.
respecto a cierta población
So,
específica,
next, we'll talk about
pues
system
fijaros que
accommodation, which is
hay un gran
regardless of
número de
setting,
farmacias
how do
según
people
ese
actually
ratio.
access
Vamos a
care?
ver ahora
And so,
cómo
for
el,
methadone in the United States,
los
a
pacientes
travel
tienen
time to
acceso
OTP, as
a
I've showed with these
estos
graphs,
tratamientos.
can be
Bueno,
prohibitive, especially in
Estados
rural
Unidos, como
areas
lo
where
habéis
there's
visto
no
con el
telehealth
mapa,
option.
está el
Whereas in
tiempo
France,
de
travel to the
desplazamiento
SAPA for
para la
initiation can be
OTP más
challenging, and a
cercano
community
es
pharmacy may
claramente
be more
prohibitivo.
accessible.
No hay
Telehealth
opción
is also
de
permitted.
teleasistencia,
When
mientras
we
que
look
en
at the next
Francia
row,
tenemos
opioid
desplazamiento
treatment program
al
hours in the
EXAPA
US
mucho
can be
más
very
accesible.
restricted. For
Existe la
example, sometimes
telesalud
patients need to show up
y en
there
Estados
between the
Unidos
hours
para
of
la
6
metadona,
a.m. and 10
los horarios de
p.m.,
la OTP
which can
son
be
muy
very
restringidos.
challenging,
Por
particularly if people
ejemplo,
don't have a roof over their
los
head or don't have
pacientes solamente
transportation.
pueden ir
In France, they're
un
typically
tiempo
full
muy
day. And again,
limitado,
it's
lo
not
que
universal
plantea
in the
más
US that these are
problema
restricted
porque
hours,
hay que
but certainly there are
desplazarse
clinics that are such.
a veces
Uh,
durante
wait
horas. En
times
Francia, sin
to enter an
embargo,
opioid treatment program
normalmente
in the
se
US
puede acceder
vary.
a lo largo de la
Some
jornada,
OTPs can see
toda la
patients same
jornada.
day,
Y en
and
Estados
others it
Unidos,
may be
los
weeks.
tiempos de espera
In
varían
France,
para
I don't have data to
acceder
support this, but
a
in talking with a
ese
number
mismo
of
programa.
people
Puede llegar el mismo día o esperar durante
nationwide,
semanas.
SAPA
En
wait times
Francia no
can
tengo
vary, and it
exactamente
sounds like
los datos,
it
pero cuando
likely
yo
may take
hablo con
months.
diferentes
I think this is a
compañeros
really
y
important
colegas,
issue when we think about
observo
potential
que el acceso al
gaps
SAPA
and
también puede
opportunities.
variar
And then when we look
igualmente
at
mucho.
access in terms
Y
of
esto puede
insurance,
a veces
insurance
tardar
access in the
meses
US
para llegar
varies
al SAPA.
widely,
Y
and in France,
luego
care is
está
free
el
and
tema
anonymous.
del acceso al seguro que varía
Buprenorphine
mucho en Estados
access,
Unidos,
when we look
mientras
at the
que en
US, there's a
Francia
persistent
la
shortage
atención
of
es
buprenorphine
gratuita y
providers in many
anónima.
areas. And
Respecto a la
however,
buprenorfina, en
the
Estados
COVID
Unidos hay
telehealth
una
flexibilities, as I said, have
persiste la
improved this.
escasez de
They're
proveedores
extended
de
through the end of 2024, and with a lot of
buprenorfina en
activism,
muchas
I'm
zonas,
optimistic that
digo
these will
bien,
persist.
y
In France,
también
buprenorphine is widely
desde
available. Telehealth is also an
2023
option.
ha
And as I've
habido
said, the insurance issues
una
are like for
extensión de
methadone.
las posibilidades. Están
So
apareciendo
next,
los primeros
just want to talk briefly
posibilidades de
about the
telemedicina.
experience in
Esperemos que se
care and really
mantenga. En
thinking
Francia es
about
diferente.
once patients
Y ahora voy
can
a hablar
access
un poco
care,
de la experiencia
what is
respecto a
their
estos
experience like?
cuidados.
How
Una
often
vez
are
que
they
los
asked to
pacientes tienen
appear for
acceso
care,
a
for
esta
visits,
a
shared
estos cuidados, ¿cuál es
decision-making,
su
including
experiencia?
around medication
¿Cuál es la
doses,
frecuencia de
and other
visitas?
treatment requirements?
¿Acaso se comparte la
So
toma de
one of the
decisión
things that I
respecto a las
particularly find
dosis
the most
de
stunning from
medicación
my
u
experience
otras
in both
condiciones
settings
para
is
el
the
tratamiento?
frequency of
Para mí,
methadone visits.
uno de
And
los
so
aspectos
what I wanted
más
to do to show this was
curiosos
just take an
en los
example
dos
of a
países
patient
es
who's
el
newly
calendario de
initiating
visita para
methadone
la
in the US
metadona.
versus
Por
in
ejemplo,
France.
tomemos un
And
paciente
I've
que
sort of,
empezaría su
this hypothetical
tratamiento en
patient is
Estados
relatively
Unidos
medically
o
and
en
socially
Francia
stable.
con
So
metadona,
in the
digo bien,
US, on days 1
y
through
digamos que
4, and
este
this
paciente
is
es
by
bastante
rule,
estable
and
tanto desde el
federally
punto de vista médico como
sort of,
socialmente en Estados Unidos, y
regulated.
eso lo dice la
Patients
ley,
have to come every day, Monday
está
through Saturday.
reglamentado,
In France, for
pues
the
los
first
pacientes
2
deben de
weeks,
ir
patients
todos
come
los
daily,
días
Monday through Friday.
de
For the
lunes a
subsequent
sábado,
days, weeks,
mientras
days
que
15
en
through
Francia
28,
durante las dos
patients
primeras
continue to
semanas
come daily in
van
the
de lunes a
US, 6
viernes,
days a week,
luego a
whereas in
partir
France they come about
del día
2
15
times
los pacientes
each week.
tienen
Then
que ir al
continuing
OTP
on for the next
diariamente
several
en Estados
weeks,
Unidos, mientras
again,
que en
6
Francia
days a week in the
es
US
2 veces
versus
a la
once
semana,
every 2 weeks
luego a
in
partir del
France.
día 29
Moving on,
todos
that
los
shift,
días de nuevo,
again, exactly
de
when
lunes a
that happens
sábado
is
en
at the
Estados Unidos,
discretion of the
mientras
clinician,
que
but
en
they
Francia
make
es
shift from getting their
una
medication at the
o 2
SAPA
veces
to
por
then getting
semana.
their
Por
medication
lo
at the local
tanto, hay un
pharmacy.
cambio
And then when we look at after
al
a
hecho
period
de
of
poder
90 days,
obtener medicamentos por
in the
el
US,
EXAPA
if
o
patients meet,
conseguirlo por la farmacia,
basically meet stability
mientras que en Estados
criteria
Unidos
based on these 8-point criteria,
los
they can then
pacientes,
sort of liberalize
pues
their dosing frequency to 5 out of
únicamente
every
si
7
realmente
days,
a
versus in
justificar
France, visits where they may
comportamiento
be able to go
estable,
to the pharmacy once every
podrán
28
empezar
days.
a partir del día
And
91
just displaying this
yendo al
difference
OTP de
visually,
forma
you can
menos
see that
frecuente.
the
Bien,
dosing
para
frequency is
explicarnos
really
un poco
quite
esa
stunning. And if we look in
diferencia
that first
de
90
forma
days,
aún más
in
visual,
the US,
observen
it would be
la
77 visits to
frecuencia
a
de la
methadone
visita
clinic as
con
compared to
respecto
19
a
in France.
metadona.
And the subsequent
Estados
90
Unidos
days, it would be
serían
64 as compared to 6
67
visits.
visitas a la oficina de
So again, when we think about
metadona
this
respecto
concept of
a
minimally
64
disruptive
más
medicine
antigua.
and minimally
Y en
disruptive care,
Francia
you
llegamos
know,
a únicamente
the
6
showing up at
visitas
that
al
clinic
final
every day is so
de
disruptive.
de
Methadone
este periodo
dosing
de
is an
tratamiento.
interesting
Por lo
question
tanto,
and different in
el
the US and
paciente
France in
tiene que
part, I
ir
think,
todos los
because,
días
or
a
there
la
may be different
clínica,
needs, in
y
part
eso es
because
muy
of fentanyl, or
perturbador
largely
para
because of
su
fentanyl in the
diario
United
en Estados
States.
Unidos.
But in the US,
También
federal
hay
guidelines
diferentes
recommend
necesidades,
starting that,
pero
or require,
las
excuse me,
guías
that the
federales
first dose is no
recomiendan
more than 30
o
milligrams.
requieren más bien
Patients
que la
can
primera
receive a second
dosis
dose of 10 milligrams
sea
on their first day.
inferior a 30
And
miligramos
then in general, the recommendations are to increase every 5 to 10
para la
milligrams
primera
every 3 to
dosis
5 days.
y luego
There's
una
nothing
segunda dosis de
saying
10
that
miligramos y
this
se
is not
puede
regulated
aumentar de
after that
5
first day.
miligramos
However, in my
de
experience, there is a lot
cada
of
3 a 5 días. Es decir, que
hesitation
está
to go faster than
reglamentado.
that
Sin
by many
embargo,
opioid
según mi
treatment program
experiencia,
physicians.
hay
In France, the
muchas
starting
dudas
dose
para
is 30 to
aumentar
40
esa dosis
milligrams,
de
generally
metadona. Es
increasing
muy
10 milligrams every
conservador
3 days as
el
needed,
planteamiento, mientras que en
and
Francia
it is
la
at the
dosis
discretion of the
es de
clinician.
30 a 40 miligramos con
And
un
then,
aumento de
and as
10
I've said,
miligramos
in terms
cada
of sort
3
of
días o
permission,
según la necesidad del
there are
paciente.
some
Ya hay un
differences. In the United
debate
States,
con
permission
el
and willingness to
médico
tailor doses
respecto
varies
a
by OTP,
la
by state, and by
autorización
individual
y la
clinician.
voluntad de
And to be able to
adaptar la
split
dosis
doses,
por parte
OTP clinicians need to get
del
approval from
Estado
a
y la
state
OTP va a depender
administrator.
de la OTP o el
In
Estado.
France,
Hay que
it's
recibir
the clinician that
una
tailors doses.
autorización del Estado para poder
Other
cambiar o
differences when we
personalizar
think
la
about
dosis, mientras
the
que en
requirement for a
Francia
physician
es el
visit. In the
profesional
United States,
el
this
que
is within the
adapta la
first
dosis a las
14 days of
necesidades del
treatment, and
paciente
often on day
respecto
one.
a la
In
solicitud
France, it has to be
de
before
y las
initiating
condiciones
methadone,
necesarias,
and it can
pues
be in
podremos
person
decir
or
que en
sometimes
Francia
via telehealth. There is
hay que
mandatory counseling in
establecer
the United States. It's required in
antes de
23 out of
iniciar la
50
primera
states. It's not
visita
required in
en
France.
Estados
Urine
Unidos,
drug tests, there's a
los
minimum of 8
consejos, las
random tests
consultas
per
son
year, and some
obligatorias
states
en
require more than
23
that.
estados sobre 50, lo que no es
And
el
generally
caso
in France,
de
there's a urine
tener
drug
ese
test at
asesoramiento
initiation and
obligatorio.
otherwise
Y en
as
Francia,
indicated.
generalmente,
Also in the US, many states
en
require
cuanto a la prueba
lockboxes
de
for take-home
droga en orina,
doses.
es obligatorio al inicio.
And in
En
buprenorphine,
caso
it's
contrario,
much
como se
less
indica.
regulated in both countries,
Y
or
respecto
in
a
the
la
US, I should say.
buprenorfina, tiene mucho
So to
menos
summarize, the widely
reglamentación
divergent
en
history and
Estados Unidos.
philosophical
Bueno, pues para
approaches between the
resumir
US and France
rápidamente,
has resulted
existen
in equally disparate methadone and
grandes
buprenorphine
diferencias
delivery
históricas y
systems,
filosóficas entre
really
Estados
notable
Unidos y
differences in
Francia,
where care is
que ha dado
delivered, who can
lugar
deliver
a
it, and
sistemas
the
de
demands placed
administración
on
de
patients.
metadona
And I would argue that the
y
France model is minimally
buprenorfina
disruptive,
igualmente
especially when
dispares.
compared with the United
También diría
States,
que hay
and
diferencia
especially once
notable en
patients
cuanto
are able to
a dónde
access
se
care.
presta la asistencia, quién puede prestarla y la
Just to
exigencia
kind of put
impuesta a
a
los
story to
pacientes y que el
this,
modelo francés
I
es
want to just
mínimamente
briefly tell
perturbador.
two
Y
patient
para poder
stories.
ilustrar esto con una historia, me
The
gustaría
first is a
hablarle
young woman
ahora
I
de
saw
dos casos
not
de
long ago in the
paciente.
United
El
States.
primero
She had a
es
severe
una
opioid use
joven que
disorder,
yo vi no
was
hace
using
mucho
fentanyl
en
about a
Estados
gram a day and
Unidos.
was in her third trimester of
Tenía
pregnancy.
un
I saw her
trastorno
in the
severo
hospital where she was
ligado a
admitted with
uso de
high-risk pregnancy and really a
opiáceos.
desire to disrupt her
Consumía
opioid use.
fentanilo todos los días.
We
Estaba en
started
su
her on, she
tercer
had
trimestre de
previously
embarazo.
disrupted
Había
opioid use
decidido interrumpir el
on
consumo
methadone treatment
mientras
earlier in her
estaba en
pregnancy, but her
tratamiento
car
con
broke down.
metadona
She lived
al
45
principio
minutes
del
from the
embarazo, pero
nearest
se le
opioid treatment
averió
program,
una
and
vez
she
el
had tried
coche
buprenorphine, but it was insufficient to control
y
her cravings. So in the
como
hospital, we
vivía a
resumed her
45 minutos
methadone,
del centro,
and
no
we
pudo ir.
really advocated with
Y
the
la
opioid treatment
buprenorfina
program
era
and
insuficiente
worked to
para
figure
controlar
out how she
su
could get there
craving, su
physically
ansia.
once a day.
Fue
But they
hospitalizada,
refused to split
reanudó
her
la
dose
metadona, pero no
and
podía
to
ir
give
a
her
diario como se le
to give
exigía.
her take-home doses for her afternoon dose, which late in
Y se
pregnancy is
decidió
often
finalmente
really
de
essential.
darle
And
una
instead said that
dosis
she could
que
do it, but
pudiese
she would have to
tomar
come
en
twice a
casa
day to the
lo que es
OTP, which would have
necesario
been
durante el
over 3
embarazo,
hours of driving
pero
a
aún
day,
tenía que ir
6
2
days a
veces al
week, and she
día
had
al
very
OTP, por lo tanto 3 horas
unreliable transportation.
conduciendo cada día 6 días a la semana.
By
Y
contrast,
no tenía
this is a
medios de
patient who I had the
transporte.
opportunity to
Sin
see with
embargo,
Dr.
le voy a
Icart
contar la historia
in
de
Lyon,
una
who was a
paciente que
young man with
tuvimos ocasión
opioid,
de
cocaine,
seguir
benzodiazepine
en
use disorders.
Francia.
He had anxiety and
Este
paranoia,
paciente de
and he was
Lyon,
seen in
un
clinic where he
joven
presented with
con
his mother.
trastorno por
Again, this is an
consumo de
outpatient
opiáceos,
setting, a
cocaína
specialty addiction
y
setting.
benzodiazepinas,
Previously,
presentaba
he
una
had been
ansiedad y una
reluctant to enter
paranoia.
residential treatment.
Fue atendido
However,
en la
recent
clínica
changes
donde se
prompted his
presentó con su
motivation.
madre.
And in clinic, he
anteriormente
was
se había
expressing
mostrado
increased
reacio a iniciar
cravings.
un
They increased
tratamiento
his methadone
residencial,
dose,
pero los
offered a
cambios
short course of
recientes le
benzodiazepines,
motivaron.
given some heightened anxiety,
Tuvo un craving,
and
le aumentamos la
counseled
dosis de
regarding overdose
metadona, también le
prevention and harm
ofrecimos
reduction. coordinated follow-up in clinic, and
disciplina
then
para tratar su
within 10
ansiedad
days had a
y
plan to enter
se
withdrawal
le pudo
management
seguir
and then
en la
directly get into
clínica y
residential
en 10
addiction
días tenía
treatment.
un plan para empezar
So
el,
as we think about the
la gestión
implications
de
and
la
structures of these
abstinencia
systems,
en un tratamiento
again,
residencial
I'm
poco
just starting to
después.
kind of
Cuando estamos viendo la
explore these, but
implicación
I
y la
think in the
estructura de
US,
estos dos
we
sistemas,
know that
yo
studies of take-home
solamente
doses
estoy
during
ahora
COVID showed increased
analizando este
treatment
tema, pero
retention
en Estados
and
Unidos se han
no
hecho
increase in
estudios
overdose
para
deaths. There's a large
poder
movement underway to
tomar
reform
metadona
methadone systems in the
en
US, and yet there remains a lot of
domicilio.
resistance to this
Hay
at
necesidad
multiple
de
levels.
reformar este
And,
sistema de
and I
la
can't help but wonder
metadona
if
en Estados
decades-long
Unidos. Hay mucha
experience in France
resistencia
could
para
address
hacerlo,
particularly some clinician and
pero
policymaker
pienso
fears
que
of
la experiencia
liberalizing
en
methadone
Francia no
access
permitiría
related
abordar
to visit
muchos aspectos
frequency and delivery in OTP versus
respecto al
pharmacy
acceso
settings.
o la visita, la
I also think
frecuencia,
that
el
it's
hecho de
important for
poder
France to recognize that
dar los
if methadone
medicamentos no
demand
solamente
increases,
por
or
parte
perhaps
de los
even
TP,
without
sino
a need for
a través
increased
de una
methadone
farmacia.
demand, but certainly
Y
in the
si
case of
la,
fentanyl in France,
la demanda de
long wait
metadona
times at the SAPA may
aumenta
pose
en
significant
Francia,
risks, and it may be
pues
important to consider
se
ways to
puede
expedite
también
access, including, for
explorar
example,
que
whether or
los
not patients need
tiempos
to be seen by a physician
podría
before they dose,
ampliarse y podría
and thinking
incurrir
about
a
primary
grandes
care
riesgos. El hecho
initiation.
que estos pacientes
So
no
with
puedan
that, I
ser
want to
visitados
extend a
por
huge
un
thank you
médico para
to
recibir
for
dicho
Benjamin, Professor
medicamento.
Roland,
Sobre
the
ello,
entire
quiero
team at
agradecer
SWAL, and
al
others in
profesor
Lyon who so
Roland,
graciously are
Benjamin y
hosting
todo
me.
el equipo
I want to
de
thank Marie
Lyon
Geoffrey
que me han
Roustide, who's been
acogido
helping on this work, and
y me han
also my team
ayudado,
at
la
OHSU.
profesora
Thank you very
Marie-Geoffrey
much.
Roustide y con todo el equipo. Muchísimas gracias por su ayuda.
Thanks very much, Honora. We'll have some questions at the end, hopefully.
Dejaremos
So
la
the
pregunta
next
para
speaker
más
probably
tarde.
needs
El
no
próximo que va a tomar
introduction,
la
but I'm going to
palabra,
introduce him anyway.
pues,
So it gives me great pleasure to introduce Professor Karl MANN, who was the first chair in addiction research in Germany
profesor Karl MANN.
in 1999. And I think the growth
Estoy
of addiction
encantado, como
research in
digo,
Germany owes
de
a lot to
presentar
Karl's
a
pioneering
Karl
work.
Mann, que viene de Mannheim,
He's Professor
en
Emeritus at
Alemania.
University of
Es
Heidelberg.
profesor
He's
emérito de la
also
Universidad
founding
de
president of our
Heidelberg.
society, the
También
European
es
Federation of
presidente
Addiction
de nuestra
Societies.
asociación,
And he's going to speak
la
to us
EUFAS,
today on
y va a
comparing
hablarnos hoy
guidelines on alcohol misuse
para
between
darnos
France and
algunas
Germany.
recomendaciones en el uso abusivo del alcohol y va a realizar una comparación entre Francia y Alemania.
Thank you, Colin, and
Muchísimas
good
gracias,
afternoon.
Colin. Buenas tardes.
Excuse me. When I accepted this invitation to talk about
Al
this
aceptar
topic, the
esta
invitation by
invitación
Benjamin
para hablar
Roland,
sobre este
I
tema,
said,
la
well,
invitación
this
de
is kind of a
Benjamin
dry
Roland,
matter.
dije, bueno, pues, ¿cómo lo
And
planteo?
it is indeed. But on the other hand, it is an important
Es un
matter
tema
for
importante
different reasons.
que
And
debemos
then I
tratar y por
decided
distintas
maybe I'm
razones. Por
not
lo tanto,
talking
dije,
about the
quizá
most
no voy a
recent
hablar tanto
recommendation,
de
like
las
20, 30,
recomendaciones
40
más
recommendations in France or
recientes
in
en
Germany,
Francia o en
but
Alemania,
rather
sino
about
más
the
bien
process
quizá
of
debo hablar del proceso
establishing these guidelines. How is
de
this
definición de estas
being handled in
recomendaciones,
France and in
cómo se
Germany?
definen
And
estas
what in the
recomendaciones en
future could
Alemania
be a
y en
potential
el
role of
futuro, cuál
EUFAS
sería el
in
papel
facilitating
potencial de
these
la
processes
EUFAS a la
and
hora de
maybe in
facilitar este tipo de
also
procesos y a la hora
doing this
quizás
together with
también
some other
de
countries in order
colaborar con otros
ease
países
the
para
process. So I
facilitar
thought
este
I would
proceso.
concentrate on that.
Creo que
So I
deberíamos
have
concentrarnos en eso y por
had
eso
the
voy a
pleasure of collaborating with
concentrarme yo
Henri-Jean
mismo
Aubin
en
from
este tema
Paris, the
en
University
mi
of Paris,
presentación.
for many years, also
He
in this
trabajado muchos años
realm
con la Universidad del País con el
of
profesor
guidelines, and so he is a
Henri-Jean
co-author
Aubin
of this
del Centro de
talk here
Investigación
today, and
en
all the information
Epidemiología y Salud
about
de las
France comes from
poblaciones.
him, and the
Toda la
information about
población que voy a dar sobre
Germany, of
Francia
course,
viene de
comes
su
from
trabajo
me.
y la
And I would like
información que
also
daré
to
de
make two
Alemania
more
viene de mi
points
propio
in
trabajo.
this
Me gustaría
introduction,
también
which
decir
is, first of
en esta
all, that
introducción
Colin, the chair
que
of this symposium
Colin,
here, is kind of
el
the,
presidente de este simposio,
can I call it the father
es el padre
of guidelines. He has
de
been
las
the coordinator of
recomendaciones, ha
the
sido el
NICE guidelines
coordinador
in the
de
United
las
Kingdom. In
recomendaciones de
2011, for
Reino
instance,
Unido.
was
En 2011, por
the main
ejemplo, fue
publication of these guidelines, and they have guided us in France and in
el
Germany
momento
to
en
a
que
very large
se
extent.
publicaron estas
And I will show you a
recomendaciones,
few examples of
vamos
that.
a ver algunos
So we do
ejemplos de
have some
ello. Entonces
expertise
sí que
here, and
contamos
all
en
the
la
questions
sala
that you
con
might have, I
expertos y
cannot
todas las
answer. Just
preguntas
put
que
him over
tengan. Yo
to
desde
Colin.
luego
So
no las voy
don't
a
be
poder
shy.
responder. Hay que
Just ask whatever you
planteárselas
want.
a Colin, que está
Okay.
aquí. Tenemos la suerte de tenerlo
So
aquí. Por lo
why
tanto,
do we
se
need
las pasaremos después. Bien, procedo a mi presentación.
guidelines, and
¿Por
what
qué
could be the
necesitamos
role of EUFAS? I
recomendaciones?
mean, you
¿Cuál
have seen
puede
this
ser el
before.
papel
The goals
de
of EUFAS, or some of
la
them, in
EUFAS?
my mind, the goals are much
Bien, yo
easier
creo que
and
los
much more limited
objetivos
in other
principales de
people's
la
mind.
EUFAS
So these are the
son
three most
bastante
important, I think.
limitados
And
y
one thing is
sencillos. Hay gente que no
benchmarking.
está de
So
acuerdo
that is
conmigo, por
about today.
supuesto.
This
En
talk is
primer
about
lugar,
benchmarking.
bueno,
How
pues se
about
trata de
in
hacer
France? How about
comparativas,
in
¿no? Y por
Germany?
eso
And what
estamos
can we
aquí, ¿no?
learn
Para
from
ver qué
the
pasa en Alemania, qué
mistakes
pasa en Francia,
that the
qué podemos
Germans have made,
aprender
the
de lo
French
que
have made,
ocurre
and how
en un
can
país
we
o en otro.
learn from the other
¿Cómo
countries?
podemos aplicarlo
So
a
what is a
nuestros
guideline?
países? Bien.
You see a definition
¿Qué
here.
es
Practice
una
guidelines,
recomendación?
systematically
Bueno, una
developed
pauta, ¿no?
statements
Las pautas
to
de práctica
assist
clínica son
practitioners
declaraciones
and patients'
desarrolladas
decisions about
sistemáticamente para
appropriate
ayudar a
health
los
care.
profesionales y a las decisiones
Very
de los pacientes
straightforward. It has
en
some very
relación a una
important
atención
elements here.
sanitaria adecuada.
One
¿Qué
is,
elementos
for
importantes en esta
instance,
definición?
patients'
Por
decisions.
ejemplo,
So
hablamos
what
de
we're doing,
decisiones de
what we're
los
trying to do
pacientes.
with the
Bueno, lo que
guidelines
estamos
is
intentando hacer con
to
estas
inform
recomendaciones
patients
es informar a los
what could be
pacientes
a choice for
sobre
their given
qué opciones
problem
tienen
with their health care.
cuando tienen un
And not
problema
only that,
sanitario.
but also
Y
in
no
the
solo
process
eso,
of
sino que en el
developing the
proceso de
guidelines, we
desarrollo de
include
las
patients.
recomendaciones
So there are
incluimos también a
patients
los
sitting
pacientes. Por lo
with
tanto, hay
us,
pacientes
with
que
the
se sientan con
professionals in
nosotros,
those
con los
rooms,
profesionales.
talking about potential recommendations, discussing the evidence in the literature, etc., etc. So that is a very important piece of that work, which has not been so much used and done before we started to do this guideline process. The other thing is, and we'll come back to that, systematically developed, etc., etc. But let me give you one more example why I think we need guidelines. Of course, there's 1,000 different treatment approaches in the alcohol field, in the drug field, in the smoking cessation field, etc., etc. And one example I like to cite always is the lemon cure of alcoholism. Do you know the lemon cure of alcoholism? 29 lemons within 1 week cures alcoholism. Great. Or another one is the double chlorated whiskey treatment for alcoholics. Ever heard of that? It did exist, and another 50 of this kind did exist, and a lot of people were making a lot of money by advertising this and by offering this kind of treatment in their treatment units. And in order to put this into perspective, we do, of course, need double-blind randomized controlled trials. And once you have them, you may have 2 or 3 or 4 with different outcomes. So how is the practitioner and how is the patient able to sort out what is the right recommendation for him or her? So for that reason, you need this process of discussing and weighing and quality control in these guideline groups to then come up with a recommendation. Okay, this is what we would recommend, and this is what we not recommend. Okay, so in France, there is this French National Authority for Health, Autorité de Santé, which has come up with recommendations how to do bonne pratique, so how to do good practice, and how to do clinical guidelines. And that is quite interesting because they said, well, what you need is that these guidelines that you produce have validity. They have to be a source for medical education, and there should not be a conflict of interest. And that is for good reasons, because in the past, as we all know, there were quite a bit of interest, for instance, by the producers of treatments in pharmacotherapy, but also in psychotherapy, by the way, who pushed their own lemon cure, if you want, and that should be ruled out according to this French authority, national authority. But then, and they used this approach Henri Jean Aubin told me in the example of tobacco dependence and treatment of tobacco dependence, smoking cessation, and the result was that all the experts that they wanted to invite had some kind of relation with treatment producers, with pharmacotherapy, et cetera, et cetera. So in that group of guideline producers, there was not a single expert. So the result was that they did provide guidelines, but they were completely useless. There was nothing you could really draw out of that. And that is the reason, I'm just citing Henri Jean Aubin here, that is the reason why for the alcohol guidelines, which were done in 2012, 13, 14, they decided not to follow this example or this recommendation of the French government, which is by itself already interesting. So the experts decide not to do what the government tells them to do. Interesting, but France is the country of liberty and equality, etc. So it's still, it seems to be still alive. That's very nice. Okay, so they did it in another way. So they included the expert. They, because of that negative experience they had with this other approach, and of course, they were much faster than this tobacco guideline, for instance, with these non-experts. Okay, so how did that go? Well, first of all, back to Germany. So there is something similar, not from the government, but from an association of the so-called scientific medical societies, RWMF, in Germany. They have about 180 medical societies, like for surgery, for ear, nose, and throat, for, I don't know, for kidney diseases. And there's also one out of the 3 societies in addiction that we have one. Ours, by the way, is also part of that. So they have come up with recommendations how to do these guidelines, and I will walk you through a little bit the recommendations that were used in France and in Germany. Okay, and here are the recommendations or the levels of evidence that you can get, and the how would you call that, the certainness, the sureness that some of the recommendations are very, very good and very well founded in science, and others are not so much. So there is one, for instance, where you have no representative guideline panel expanding, working on that, no systematic evidence, and no formal structured process in discussing. That would be the S1, the old one, and some of the fields in medicine still are on that level. Of course, down here is the other extreme, the so-called 3-level or S3 guidelines. There you do have a representative guideline panel, which means that all the stakeholders in the country have to be part of that process. In our case, where we did alcohol guidelines and tobacco guidelines at the same time with the same group of people, that meant 50 to 60 people, you know, experts, but also relatives of patients, patients themselves, and stakeholders from all kinds of involved authorities, treatment providers, et cetera, et cetera. So that meant representative guideline panel. Systematic evidence, of course, we'll come to that. And then also something maybe very German, when it came to the decision and the voting on recommendations, then you had a formal structured process. Not everybody could talk at the same time. Something hard to imagine here in ATHS or in France, maybe. No, this was a joke, Benjamin. Okay. Anyway, so there is a structured process, which is nice to have, so that you don't lose too much time in coming to a decision finally. Okay. Now, for these guidelines, you had first to have the idea, what do we want to talk about? Then you had to have a developmental group. Then you had to establish the clinical questions, systematic literatures, et cetera, et cetera. In the end, you have the full guideline. And then the question is, how do you disseminate and implement and evaluate that stuff? Going back to France, a little bit of the history of these guidelines, you know, it started like in 99. about indications, aims in the alcohol field, and then we had something like alcohol drinking during pregnancy, and the most recent ones were at that time the alcohol misuse screening, diagnosis, and development. And we are talking about this one here compared with the German one. Okay, here is how it was done in France. They did have a steering committee, of course, talking about methodology, planning, etc., bibliography. Then they had a work group doing this kind of work with different versions. And then they had a review group. And that is interesting also for the context of this meeting and this symposium, because the review group was consisted of people expert out of EUFAS. So EUFAS was used for these French guidelines as an external reference group, review group, and which gave their consent or gave their recommendations or critique or whatever. So that is how that happened and was done. And here are the names of these people, François Paille, Henri Jean-Aubin, Madame Gillet, they were in the steering committee. I was invited into this work group. I was invited to work with them. And then the review group I just mentioned, there was like Professor Drummond here, there was Conor Farren, one of our newly elected members of the EC of EUFAS. There was, Manis Scafato and Friedrich Wurst, who's also in the audience today. So people who have been working with guidelines for a long time, they spent some time in doing these reviews. Okay. So how is this being developed, such a guideline? In the example of Germany, first there was the clinical question, and you can see in the alcohol field we had 22 overall questions. For tobacco we had 29, and we came up with those with the Delphi process. So I don't have to explain the Delphi process here, I think. The next step was we were looking now at the international guideline. We have a given question, and then we look, is there already something there which answers that question, for instance? So we were looking at this, and we found, I can't really read it here from here, like 20 some international guidelines in alcohol and 18 in tobacco. But then we had to do a quality control of these guidelines and say only if they are beyond a certain score, which has been published and validated, etc., the Delphi score, then we can use these guidelines to answer our question. So if yes, then it went into a treatment recommendation. And that consists of a level of evidence. How good is the scientific evidence for the question? Should we take nicotine replacement, yes or no, or should be this or that drug, or this or that psychotherapy? And then that comes up with a level of recommendation with A, very strong recommendation, B, not so strong, but still evidence, and 0, we don't really know, but it looks not too bad in a way. So if there was not an international guideline, then we had to do the systematic reviews ourselves. We had to look what is there. Again, they were quality controlled. And after that, if there was nothing there for us to answer that question or any of the other questions, then we had to do the systematic reviews ourselves and do the meta-analyses and look at the RCTs. And that is extremely time-consuming. We produced a book of 500 pages in the alcohol guideline, which has the results of these systematic reviews and RCT results, also with the commentary. How good or bad, or how well does this fit to the German situation, etc., etc. So an enormous amount of work, a lot of money going into this, and really a reason to call for international collaboration, because why should we do it all by ourselves and not ask our friends from Holland, Wim van den Brink here, how are they doing it, and why don't we do it together, for instance? Okay. So these are 3 examples now from the German guideline, very simple and very clear-cut and evident. I think the audit should be used and should be done. Strength of recommendation A, level of evidence 1A, very good. And then we had to vote. So the consensus you see in that group of 60 people was 93%, not 100%, funny enough. Although the strength of recommendation and the level of evidence, independent of the voting, was very strong. And then another one, short interventions, etc., also pretty clear cut. And then the third one was maybe the most interesting at that time. I think that still holds true. How about harm reduction in the alcohol field? Can we think of treatment goals which are short of abstinence? And you can imagine these 50, 60 people also representing the rehabilitation hospitals, which have made their money for 40 years following the abstinence paradigm in the alcohol treatment field, how they feel about this and how they are going to vote about this. So that was a very difficult, cumbersome discussion. Here we were extremely happy that Colin Drummond had worked on this before. And in one of our conversations, he said, you know, when they were discussing this for the NICE guidelines, a lot of blood was being spilled. And that was true for us too. But then everybody was so tired at the end that we came up with this compromise, if you want, and we had a consensus of 100%. It was like in the old days in 1968, you know, everybody's tired, then, oh, okay. Well, anyway, but this was a step forward because that opens the door to some first step into harm reduction in the alcohol field, allowing for treatment goals short of abstinence, which means reduction or the so-called controlled drinking. Okay, so these were some examples. Now let's compare the two models, and this is again a slide that Jean-Aubin has prepared. You can see there was, as I said, a large working group east of the Rhine and a limited working group west of the Rhine River. And this group process and here the limited bibliographic review. And now is one point which we will look into closer, the industrial funding and the conflict of interest. So there was no industrial funding in the German side because of the AWMF guidelines. There was industrial funding in France in spite of the national authority which claimed or which wanted them not to have an industrial funding, etc. There was as a pretty strong internal validity in the German thing. It take almost 5 years until the publication. And on the other side, there was this external validation by EUFAS, and it took a year and a half. So there are strengths and weaknesses on each of these sides, and we can learn from that. And we can now discuss how can we get this and put this together. But that may be something which I'll come to in 2 or 3 minutes. Let's first have a look at the conclusions. Well, I think I've really touched upon this. What's also important is this focus on GP practice in France and also to a certain extent in Germany. It was not only for the specialists, but it was also for a broader field in the MDs, but also clinical psychologists, of course. Okay, now the financial disclosure. I don't know how much the French guidelines costed in order to be done and published. I do know for the German guidelines, the alcohol and the tobacco cessation cost 500,000 euros. And this was not government money, it was not industry money, it was financed by the societies, by the scientific societies and by some of the academic centers like my own. So I put at least 100,000 euros workforce, working hours by my staff into that. So very, very costly, very expensive, but no industrial funding. And for the French side, you can see that there was some funding from the pharmaceutical industry. Now, the conflict of interest in you don't need to be able to read the right-hand side. It is defined here on the left-hand side. And what we did in Germany was that every year, each of these participants had to declare their conflict of interest. So did I get some money for some consultation of a pharmaceutical company? And if I did, then I could discuss, but I was not allowed to vote. So I was excluded from voting for this specific question. But also in the same way, if I was the president of a society for behavioral psychotherapy, then I could discuss, but I was not allowed to vote on which kind of psychotherapy we would recommend. So again, pretty complex, not easy to do process, but it did work, and it was not really then all that complicated in the end once we got used to that. And it also was true, I think interestingly enough, for people who were treatment providers, like some people who owned hospitals in the rehabilitation part of treatment programs in Germany. So if that was there, then if we decided, we discussed a point concerning hospitals and the hospital, the system in which patients are being treated, then this person was not allowed to vote in that respect or for that recommendation. So in summary, it brings up some clinical recommendations, of course. In the alcohol field was 172 recommendations. In the tobacco field, I think we had about 80 or 90. And so we can recommend some of these things. Which another thing which is also important, we can also say this treatment approach does not work. This is nonsense. This is rubbish. Like the lemon cure of alcohol is complete rubbish, of course. So we could say that also for some other approaches as well. Okay, I've touched upon the others. And I want to finish with something that, how about the splendor and the misery of guidelines? So there's some splendor for guidelines, but there's also a lot of misery for guidelines. So the splendor would be you facilitate diagnosis of the disorder. You can assist health professionals, patients, and families to find the best treatment available. You can reduce inappropriate variations in care. You can provide a focus for education, also for training and future research. So that's the nice part of it, and I think it's true. Be interesting to hear your opinion about this later. The misery of guidelines, well, of course, they're extremely costly, and that was for me the most cumbersome point. You do not get rid of bias in spite these enormous efforts, by taking out conflicts of interest, by looking, is there 100%, is there an evidence of 1A or is it only 2B? And then that has to be weighted against side effects, for instance, but not only in the pharmacotherapy field, also in the psychotherapy field, because there are side effects in psychotherapy as well, or undesired effects, if you want. So that was a discussion which was very difficult. And in many cases, we did barely make the 75% congruence in the vote. And so that was really interesting to see. And then, of course, when you publish them, they're already outdated, which in a way is true. We did publish with Jürgen and with Colin in the European Addiction Research, we did publish a benchmarking systematic review also of guidelines in the alcohol field in Europe. So if you're interested in that, it's not on the slide, so that's worth looking at. Well, then there needs to be follow-ups, and they are necessary, but are they manageable, and how can that be done? I think I forgot, it was one of those slides also. There are both in France and in Germany updates of these guidelines. So if you're really interested, if you want to know what are the most recent recommendations, there's an update in Germany from 2022, I think, and in France in 2023, or the other way around. So there are updates there. And in the case of Germany, there is not so much really different from what we published 5, 6, or 7 years ago. Okay, so what can be the role of EUFAS? As I said, maybe, I'm not sure, of course, maybe we could convene member societies which are working on guidelines and see whether we can at least do some of these processes together, or whether we can learn from each other. That is something that EUFAS could offer and would be ready to offer, I think. Again, based on the British groundbreaking work 10, 12 years ago, and the continuation of that work in the UK. So that would be something that I could see as a step forward and as a contribution of EUFAS for the field. Shall we reinvent the wheel? Well, maybe not. I don't think we need it. And you can see here 4 examples. There are, of course, more of guidelines which have already been published, and we do need international collaboration and benchmarking as well, and counseling, etc., etc. So here's Henri Jean-Aubin and myself, and you can see what I said. Bottom line, l'union fait la force. Thank you very much.
Thanks very much, Karl. So the next part is the EUFAS European Addiction Research Award, which I'm going to introduce as president of EUFAS. This is an award that's been in operation since 2016, and it's a collaboration between EUFAS and the journal European Addiction Research. The award goes to a scientist in the addiction research field who's made an outstanding lifetime contribution, particularly in relation to human research. Each year we invite nominations from our member societies, of which there are 32 across 24 countries. The decision on who to award this to is made by a nomination committee chaired by the past president of EUFAS, which in this case is Geert Dom, who unfortunately can't be with us today. The committee also includes the editor of European Addiction Research, who is currently Professor Karen Ersch. The awardee is then invited to give a lecture and also to submit a publication to European Addiction Research. This year, the award goes to Professor John Marsden, who many of you will know is Professor of Addiction Psychology at King's College London. He's conducted extensive research on evaluation of novel psychological and pharmacological treatments for drug misuse. And he's also chief editor of the journal Addiction. So John unfortunately cannot be with us today, but I'm hoping through the miracle of technology, we will see his award lecture anytime soon. How's it going?
Do you want to say
Please slides.
À la régie, s'il vous plaît, si vous pouvez envoyer la vidéo. Merci.
We'd like to have a video for the prize recipient.
I'm deeply honoured to receive the EUFAS award this year. I'm also very sorry not to be able to join you in person, but I'm very delighted to record this presentation for you on the topic of interventions for opioids and stimulant use disorders, a search for effectiveness. I'm sure you'd all imagine that the occasion of this award encouraged me to look over my shoulder to some extent and to think about some threads of my clinical academic work over recent years. And indeed, the search for improving effectiveness for opioid use disorder and finding any effective intervention for stimulant use disorder has been a core thread, and one that I hope weaves together an interesting account for you at the meeting. Got some affiliations and disclosures, and the research I'm going to summarize was all sponsored by King's College London and the South London and Maudsley NHS Trust, with research costs and materials funded by Department of Health, NIHR and Indivia. I kind of ran out of space in a sense here. There's so many colleagues to thank. These are among the key investigators in the studies that I'm going to summarize, but many more could be added. So what's the structure? So I'm going to spend a little bit of time setting out the context for my presentation to you, focusing on opioids and stimulant use in the UK. I'll then offer a few words about our first-line standard of care interventions for OUD, and use some of the cohort studies that we've done to highlight how, in our context, there's a clear rationale to continue offering these interventions, but to search for ways they can be improved. And I'll then use the core of my talk to summarize three successive randomized controlled trials that my team has been doing in recent years, looking at helping harder to treat patients with OUD, and also those who have parallel or dual opioid use disorder and cocaine use disorder, which is a particularly troublesome combination for us clinically. I'll then look at our efforts to help people with cocaine use disorder, particularly those with primary cocaine use disorder, so a novel cognitive therapy. I'll then spend time looking at a superiority trial of extended release buprenorphine, summarizing those threads together and just outlining what we hope is our next trial, which actually layers on top of this previous set of trials. It's so important to set context for studies. Unless you're very thoughtful, you can immediately think about why a study should have been done in a different way in your own country context. And so in the UK, at the moment at least, we have a problem that is essentially related to heroin imported into the country with a very long established trade route, and also cocaine use disorder. If I was brought up in North America, I would be talking also about prescription analgesics and methamphetamine. We have local time-limited outbreaks of fentanyl analogs and isotonizazine compounds that are mercifully not expanded, but we are very watchful and concerned. But my story today is about heroin, and also mainly the smokable form of cocaine, which is very prevalent in the UK, sometimes called rock or crack cocaine. And as you can see, in terms of treatment, people in treatment in England, we've got two primary and quite large populations, people with heroin use disorder and people with opioid, heroin and cocaine use disorder. We do attract a relatively small number of people from the crack-using population into treatment, but they don't really stay long. And the reason for that is largely because we don't have a licensed medication to offer. And as you'll hear, our efforts to offer people psychosocial interventions are not particularly successful. There are important instrumental links between opioid use and cocaine use disorder. Both drugs can be used concurrently for their combined effect, and they can also be used sequentially in a drug-using episode to increase or offset the effects of the other drug. So, for example, someone who uses opioids might use cocaine afterwards to increase or antagonize sedation, and someone that uses crack cocaine might then later in an episode of use heroin or another opioid to manage acute withdrawal effects of cocaine. So they are instrumentally or synergistically linked in the accounts of many of our patients. And that's a real problem for them and for us in terms of passing out and trying to help the what should be the clinical targets. So I want to just summarize some cohorts for you briefly. We're very fortunate in the UK. It's rare to be able to say that, isn't it? But we're fortunate in having an almost real-time outcome monitoring system for patients that are in receipt of National Health Service and non-governmental treatments. And we're able to use cohort studies. Most of the time, our cohort studies represent everyone that started treatment in a particular year. And we can then follow up patients to look at various outcome indices of treatment response. This was the first study we did back in 2008 when we just set up this new system. 20,000 or so patients who started a medication-assisted treatment using an opioid agonist or partial agonist across England, across all English community treatments. And after 6 months, we used a reliable change index to show the proportion of people at assessment at that point in treatment who were abstaining, who weren't abstaining but had improved compared to their baseline level of heroin use. Those that essentially were using the same amount or the same frequency of heroin use at follow-up as at admission. And as you can see, 300 or so patients who were deteriorated, if that's the right word, were using more often than at admission. So if we take the abstinent and improved groups together, that's quite a strong treatment response. But obviously, we've got people that haven't abstained and those that are unchanged. And so it's a mixed picture of endorsement of our efforts for our standard of care treatments, but with a lot of headroom for improvement. And one thing we noticed early on was that patients who admitted to treatment who were also using crack cocaine, their heroin abstinence response was moderated, as you can see. So those who used heroin and crack at admission had a lower level of heroin abstinence than those who are heroin dependent only, as you can see. So that set us thinking about ways in which we should focus on targeting, helping people increase their abstinent response, targeting patients that hadn't changed, and of course, not losing track of those that appeared to need possibly a different offer or a more intensive treatment. Along with colleagues across the world, retention is always a concern. If we look at how long people stay in opioid use disorder treatment in England, so I'm coming more up to date now. This is a cohort of all admissions in 2018, so that's 42,000 people. Actually, our retention rate isn't as concerning as it is in North America, for example. But nevertheless, by 12 weeks, we've got 40% of people that have left. And we are really talking about a retention-oriented intervention that is founded on encouraging patients with OUD to stay for longer, for sure. But you can see that we're losing patients progressively each month. So our retention rate is encouraging, but shows a missed opportunity, of course, for 40% or so of patients who have left and who we would like, and they perhaps themselves would like to stay in treatment for longer. I'll address that in the third trial later on in my talk. One novel study that we've done that we're very keen on describing is a very rare study in that we also looked at 8,000 patients who never left treatment for 5 years. I don't think it's been done before. It may well have been, but nevertheless, it hasn't been done in the UK before. And so this was looking at everyone over 5 years for continuous retention. And we used some fairly arcane statistics to see if we could characterize the treatment response of that large sample of people over 5 years. We use an instrument called the treatment outcomes profile, which Services complete as an interview. It's got a little timeline follow back and some other questions with patients as often as they like, but usually every 3 to 6 months. And then that's uploaded to our National Drug Treatment Monitoring System. So here's a growth chart of the passing out those 8,000 people into treatment responses, simply on the basis of the number of days a month they used heroin over half-yearly follow-ups over 5 years. And this uses a latent growth curve model. It's pretty, as I say, pretty arcane, but it does enable us to see some tendencies over time in terms of the trajectories. And if you scan that image, you can see there's a green line at the bottom, which indicates a group of people that were essentially in treatment for relapse prevention, which is a very welcome group, not particularly numerous, 17% of the total. You can then see a group in light blue who started at about 25 out of 28 days of heroin use a month. And after 6 months of treatment, really rapidly reduced that to the point where they essentially used very occasionally or not at all. You can then see a black line that takes a slower route to a very favorable retention outcome at 5 years. So that's a slower train to abstinence, if you can see, but progressive reductions at each assessment over time. Then finally, we've got two groups that are obviously more concerning. On the one hand, we've got a red line where there may be all manner of harm reduction benefits associated with this group. But after some, whether it's regressive or some improvements to 6 months of treatment, there's not really any further reduction over time, even though they don't leave treatment. Perhaps equally concerning, but with a different profile, we've looked at some of the characteristics of these curves, which I won't belabor today. We've got a gold line, finally, where there's a very welcome and speedy improvement profile, but it seems to run out of gas at 2.5 years, and then there's a progressive increase in heroin use. And so this sustained progressive response is really welcome for this very persistent disorder. But the marginal and deteriorating response is a real call to action in our treatment system to try and reach those particular individuals and offer a different offer or different or more intensive interventions. So I want to talk about a study we did, which was focusing on what we called hard to treat or harder to treat patients with OUD and CUD. This was a single clinical study, quite expensive, in that what we wanted to do was see if we could offer a full list of psychosocial interventions. If you think of all of the ones that get reviewed by NICE or NIDA in the US or elsewhere, what would you come up with? You'd think of contingency management, you think of family therapy, you think of CBT, you think of motivational interviewing, you think of social behavior network therapy, you might think of 12-step facilitation. And we thought, well, what if we could offer all of those to the best of our ability to patients that were enrolled in treatment for our medication standard of care, but weren't doing as well as they would like or we would like. So our background theory on this was that there've been lots of different manual-driven therapies tested. But what if we threw away the manual and we just said, okay, what are the effective elements of these manuals? And could we have a much more personalized offer? But we would look pretty churlish if we didn't include some type of reinforcement, contingency management intervention. Behavioral couple interventions always features in the top 3 when reviewed internationally by systematic reviewers, and also 12-step based groups. A Cochrane review that we were very interested by, for example, concluded that among 13 different psychosocial interventions for an opioid agonist therapy as an adjunctive intervention, none were effective. And we felt as if that might be missing the fact that at a population level, you might get a null effect, but for subgroups, there might well be if you like, a patient treatment matching effect, and that's what we set out to study. We used a very formulation-based approach with our patients, fashioning a hypothesis of why their OUD was unresponsive. And we looked at various cognitive, affective, and interpersonal factors that might serve to maintain that unwanted disorder, craving, emotional dysregulation, hazardous social context, etc. And we put together a toolkit with interventions from the therapies that you can see here. And we offered all or any of these to patients according to their formulation and also their interest and preference. It was a sort of no wrong door study, and that we tried something, and if it didn't work, we were encouraged that we had always something else that we could offer. But remember, these are patients that are not responding particularly, so their characteristics were enrollment in our opioid agonist therapy service in South London. They would need to be using at least 1 day of heroin or cocaine in the past month with UDS verification. Of course, many were using a great deal more days than that. We stratified by the usual things. So we randomized to get this psychosocial intervention or to continue with treatment as usual. Our primary outcome was treatment response at 18 weeks, and we defined that as no use of opioids or cocaine during the 28 days before follow-up, and 1 or more negative urine drug tests in the previous month for heroin and cocaine, and no positive tests. So it was a sort of binary treatment response endpoint. What we found was that we certainly didn't encourage people to leave treatment, which was welcome. So at 18 months, almost everyone was continued to be enrolled in treatment. So actually our retention was actually rather encouraging. You might think back to that colored growth chart that I showed a moment ago. There was no difference in dose of drug, so there was no sort of sense of confound of our results by the level of pharmacotherapy dose. We delivered intervention by a psychology assistant team supervised by myself and 2 colleagues. Patients attended a reasonable number of sessions. 60% attended at least a third. And here's the end point. So at follow-up, 16% of participants in our PSI group were responders compared to 7 in the control group. And that's a statistically significant odds ratio. There is an economic cost-effectiveness analysis in favor of the PSI, but there's no doubt, is there, that that's a fairly low-level response, but we did manage to help patients who were not responding to medication improve their response likelihood, but it still shows a huge amount of road ahead to find even better ways of improving outcomes. Just to show a couple of secondary outcomes, when you use a more perhaps sensitive measure, percent days abstinence for both opioids and crack cocaine, there's statistically significant effects for PSI. The work and social adjustment scale was also statistically significant in favor of improved social functioning for our intervention, but not for any of the other measures that you can see there. So, second trial, having worked with patients who were not responding as well as they would like, or we would like, from medication, we really turned our attention on cocaine use disorder as a primary focus. First of all, noting that although things are changing, at that point, there was really no great endorsement that we could see of a candidate pharmacotherapy. And we felt as if buoyed up from our work with psychosocial interventions, that we might be able to provide our patients with some effective psychosocial intervention. And we, first of all, as you might expect, spend a lot of time thinking about the way in which CUD is developed and maintained. And primarily, we've got an exposure-driven process in which, previously drug-neutral objects, such as this pretty grotty-looking ATM machine in South London that I photographed, which of course has nothing to do with drugs for the majority of the members of the local community, but for a person with CUD, it's become very much a conditioned stimulus through repeated exposure. So encountering the image, the reality of an ATM in the community could induce a variety of thoughts and feelings that relate to the motivation to use cocaine. So we felt as if we needed to really think about how we could loosen those numerous conditioned processes that befall someone with a cocaine use disorder. There's been lots of effort to do that in the past using very frank exposure techniques. And we were inspired very much from work that we'd also done with PTSD. And we wanted to get much more into cognitive restructuring, getting into appraisals and the meaning of conditioned cues and the consequences thereafter. And what we did was we asked our patients to really personalize their cues for us. And we said to them, would you take this disposable camera or will you use your phone and take a bunch of pictures over the next week that, when looked at, would be a direct reminder or a trigger of your cocaine use. So it might be a picture of a place, an object, a scene. And as you can see, there's lots of photographs here of just pretty unremarkable street corners that mean nothing to us, but mean a lot to the person. Also objects, makeshift crack pipes, paraphernalia, etc. And we asked patients to do that, and we put all of what they brought into the clinic into a box. It was really crude experimental psychological therapeutics. But I make no apology for it. Very, very idiosyncratic. And what we then did was we said, okay, we've now got a box of triggers, and having formulated lots of different craving experiences in terms of fast occurring thoughts, elaborations, memories, mental images, sensations, etc. We repeated and used exposure in which we asked patients to literally open the box and to look through over the course of a couple of minutes the contents, so that we could elicit and then helpfully elaborate a whole complex array of thoughts and feelings and beliefs about the person and the world and their disorder. And then having elicited, we found it to be a very effective way of eliciting very personal thoughts in a way that showing someone a video, a standard library video, may not be sufficiently arresting for an individual. They may just think, oh yeah, that's just one of those films, isn't it? Doesn't mean anything to me. That's not the way I use it, or that's not where I buy, etc. So that idiosyncratic approach was very, very effective. We also used some film in that we filmed a facsimile of preparing a crack pipe, breaking it down into a storyboard with a volunteer patient, and then filming the various episodes in a sequence of smoking cocaine. And we played that to a patient as well. And they could select from whether it was male or female, or whether it was heroin or crack cocaine on their own, or both. So it was a small study, very, very intensive. So lots and lots of CBT, a week of cognitive restructuring and idiosyncratic exposure. but a nice effect, an encouraging effect for abstinence from cocaine at a month and 3 months in favor of our memory focus cognitive therapy. So we've now put that intervention in our toolkit. It's expensive. It's not particularly scalable given the resource constraints we have in the UK, but it is something we offer patients who really struggle and experiencing distressing, bothersome craving. So the third and final study I want to talk about today brings me up to date with a trial on extended release buprenorphine for OUD. This is a study we've been running over the last 3 years or so. We ran it during COVID, and we're reaching the welcome endpoint with acceptance for it in a mainstream medical journal in a week or so, we hope. And I want to just show you how what I've discussed already feeds into the EXPO study, and I'll end up then with some thoughts about the future. So we have got a story with extended release buprenorphine of some investigational and now 2 licensed products. There was a subdermal implant manufactured by Titan called Probuphine, and that was subject to research trial investigation, but it's now left the market. So I believe the company is now pivoted to chronic pain for this. So we don't have that one available. What we do have are 2 alternative formulations of extended release subcutaneous injectable buprenorphine. One often called Buvidal, but not always, manufactured by Camurus in a weekly or monthly formulation. The other, a monthly formulation called Sublocade or Subutex Pro in given territories, manufactured by Indivior. And the Indivior product was the one that we were able to evaluate for the first time in a superiority trial. And we compared that, just in the footnote, to all of the opioid agonist treatment standard of care medications. So that's methadone, that are full opioid, mu-opioid receptor agonists, and also all various forms of transmucosal buprenorphine tablet, polymer film, and a lyophilized wafer. So we were interested in trialing this because a lot of our patients do feel that attending community retail pharmacies for observed oral tablet or liquid dosing for OUD isn't that great. They feel stigmatized. There's a drudge of routine, and they often cite it as a reason for leaving early. So that hooked us in with our concerns about retention. Patients complain sometimes that, you know, the strictures that we put in front of safe induction and dosing and the sort of community safety arrangements are not that easy for them to adhere with. So with the Indivior product, the idea of a monthly injection is a really simple dosing option, we thought. We thought it might even achieve opioid blockade so that patients would have control over craving because of the good pharmacodynamic plasma circulating levels of buprenorphine, and that also potentially any lapses of use of heroin in our context might be blocked so that they wouldn't get the subjective effects, thereby inducing a very virtuous operant learning process that would mean that there would be no further heroin use. Lots of qualitative studies showing patient endorsement, but we also thought that this wouldn't be the offer for everyone, and that some patients would want you know, a strong primary agonist, for example. So in the background context of non-inferiority trials establishing the Camurus product, and also that we were going to, you know, draw breath and do a superiority study, I'll tell you a little bit about this study called EXPO, so extended release pharmacotherapy for opioid use disorder. It was done in 5 centres, coordinating in London, in the West Midlands, the northwest of England, the northeast, and into Scotland in Tayside, all areas with a very long-standing high-level prevalence of opioid use disorder. This was a 24-week study, open label RCT. We opened it to as many patients as would be interested. And we could include all the forms of standard of care. So methadone, all forms of sublingual buprenorphine. Doses not managed by us, or complete free titration to desired or clinical effect. We used the US manufactured product Sublocade. That was imported for us into England, wasn't available at the time. It's just received market authorization in July this year for England, which is a very welcome development. We had 2 loading doses as per the label. So that's 2 doses of 300 milligrams subcutaneously. The only difference is that because we wanted patients to get the 2 loading doses pretty quickly and flexibly, we allowed the second dose to be a minimum of 21 days rather than the label of a minimum of 26 days. And that just gave our patients a little bit more flexibility. There were then 4 maintenance doses, either 100 as per label. There could be 300 if the patient wanted that. And we just allowed patients to have a discussion with their prescriber to keep things as flexible as possible according to preference and symptom control, offering rescue buprenorphine at any time. We powered the study for 304 participants for the head-to-head. We overshot the runway a tiny bit, and in the end randomized 314 to continue in their standard of care or to receive 6 months of Sublocade. Our primary endpoint was opioid abstinence. We haven't got a responder characterization that we used in the trial I mentioned at the beginning. We wanted to capture each and every day of response over 6 months. And I'm going to use some data visualization techniques to characterize our primary endpoint, which I've become very taken with, and I think are hugely illuminating really into the pattern of response at a patient level. Lots of secondaries, I'll mention a couple. An economic analysis, which I'm not going to mention today because of time, nor some qualitative studies, but a fairly unremarkable contemporary sort of 21st century RCT across the world was expert in the sense. So we wanted to include patients with moderate to severe OUD at admission, but also those that were either not responding but retained during treatment. That hooks me back to early slides, I hope you'll recall. And also patients that might be completely abstaining but want to change, you know, fed up with daily and wanting to convert to monthly treatment, for example. We wanted to just offer it to everyone, really. They did have to convert to Sublocade within a week. So that would mean that a methadone patient would need to taper their daily medication, for example, from 80 milligrams, and we used 30 as a threshold for conversion to sublingual buprenorphine. Buprenorphine patients had obviously a much easier transition. The usual exclusion criteria for most of our trials in the field. So we identified a fairly large number of patients across the 5 sites. The majority were excluded because they were
Okay, I think we've decided, as we're now at 4:30, and John, who's ever the master of economy, already gave this presentation, this part of it yesterday. I think we should probably stop the presentation and just allow, with your indulgence, a few minutes for questions for the speakers. So any questions or comments? Yeah, go ahead.
There we go. Thank you so much. I'm Gavin Bart from University of Minnesota in the United States. I have a question for Professor Mann. So after describing the differences in guideline development, were there many differences in the actual guideline recommendations? And if there weren't, does that inform what future processes should entail?
Yeah, good question. There were not many, almost no differences in the recommendations, neither in the French guidelines, nor in the German guidelines, nor in the NICE guidelines. So basically, you know, we're aiming towards a common result. And that is one of the reasons, thanks for the question, that's one of the reasons that I think and many others think we do not need to do such a big effort in each of the countries. Would you agree, Colin? I mean,
yeah, I mean, I think for addictions, that's probably true, but you know, you might have other drugs in other fields, like, you know, cancer treatment, where, you know, you've got each course of treatment is costing $100,000, where different resource settings are going to have a very different view about the value of that kind of treatment, and possibly the health economic aspects are going to come into play more than they do in our field at this stage. But you know, so I would have thought, certainly having done the UK guidelines and then reviewed the French ones and looked at the German ones, you know, there's hardly anything to see in terms of difference between them. I'm not sure how much added value there would be now in doing, you know, further root and branch kind of systematic reviews from square one. You could probably, there will be new advances will come along which might alter recommendations. You know, if a breakthrough medication appeared on the market to cure cocaine addiction, for example, everybody would, you know, probably want to revise their guidelines on the basis of that. But I think there's probably a lot of wasted resource in, you know, doing multiple systematic reviews that are exactly the same systematic review question, reaching the same answer. So yeah, I kind of agree with that. I think Wim, you had a question.
Yeah, maybe want to continue that. We just finished a new guideline for alcohol dependence, and one of the recommendations, and that's a more general issue, do you get to the real right questions that are important? Because one of our recommendations is now every patient that comes for treatment for alcohol dependence should be offered medication against alcohol treatment. Is such a guideline or such guidelines likely to appear in these guidelines that answer the questions that we already know?
I mean, well, if I could answer that, that was one of the recommendations that came out of the NICE guidelines. You know, not only which medications, but also the fact that every patient with reaching a certain threshold of dependence should be offered this. But also another failing of guidelines often is that they look at pharmacological treatments separately from psychotherapies, and in reality, you know, we're going to offer both, and possibly detoxification at some stage and rehabilitation. So really, I think guidelines need to move from examining individual interventions to looking at a pathway of care where you specify somebody who has this level of dependence, this level of comorbidity, should expect to receive the following elements of treatment in a logical sequence and coordinated, you know, so that there's no gaps in between. And we tried to do that with the NICE guidelines again. You know, we talked about pathways of care and continuity of care as being really important, because people often, as we saw from John's talk, you know, they drop out at various stages of treatment. So making sure that people actually receive the care through, you know, effective care coordination and keeping them in treatment, you know, is quite important. But I think a lot of guidelines don't look at that. They tend to look at, which medication works, which, type of psychotherapy works.
Maybe one question for Jürgen. Did you take into account the role of psychiatry? Because that field is changing now. I know for the Netherlands, psychiatry was not involved in any addiction treatment until 10 years ago. Now every psychiatrist gets basic training in addiction treatment. And so there's on the one hand is the addiction specialist, on the other hand, there's the psychiatrist now getting a decent education also and training in addiction.
There were possibilities for the countries to report that addiction psychiatry was sort of almost a subspecialty, but it was beyond what we were able to capture within the study, the different course material that different psychiatrists in different countries, also in different ages, because this is a new novel cohort of psychiatrists coming out in the Netherlands. But so the answer is basically no. What I would recommend, though, is that people read the paper. I'm not saying that just because it's my paper, but please react and write letters to European addiction research saying that this is wrong and this needs to be nuanced and so on. So hopefully, through such a process, we will be able to build a more comprehensive picture of the situation in Europe.
Thank you. I had one for Honora, if I may. It was just, obviously, it was really interesting to see the vast differences in the way OSTs delivered in the two countries that you're reviewing. Are you able to look at the outcomes across the two countries? It's sometimes said that a high level of supervision is helpful in achieving good outcomes in OST, but it might actually have the opposite effect if people are sort of so exhausted by, having to travel to a clinic miles away every day.
Is this on? Oh, thanks for the question. I think context is so important. There are overdose data, and when we compare overdose rates, which again is just one of many outcomes, we know that at a population level, France's overdose rates, or excuse me, US overdose rates are 32 times that of France. Certainly we have fentanyl in the United States and there's not fentanyl in Europe, at least it's not predominant. So I think there's lots of drivers. But even just looking at treatment engagement, which I think is a critically important measure, we're really failing in the United States. And when you listen to patient advocacy groups and many clinicians, really the barriers to treatment and the lack of low barrier care is such an enormous challenge. There was a recent paper out in JAMA Network that Benjamin and I have discussed some that I think is really problematic in terms of how they frame the risks of methadone. Methadone and so that's a sort of a very short answer to an important question.
Okay, thank you. That's helpful. Any final points? Yeah.
Not a question, but an encouragement. Since Jürgen brought up the subject matter, it is if there are not current collaborations with the International Consortium of Universities on Drug Demand Reduction, which has almost 400 university members, they too are trying to do an international global survey of addiction training and what the needs are in order to help develop international curriculum for training through universities. So I would encourage the partnership.
Thank you. Point well taken. Okay, we're a bit over time, but I'm glad that we've all stayed to the end to have a few questions. I'd just like to thank once again the ATHS organizers for allowing us to have a EUFAS symposium here and to bring together this rich array of speakers that we've had this afternoon. So I'd like to thank them all for their excellent contributions, and thank you for joining us. Thank you now. Bye.